Hey everyone. So by now you're familiar with the anatomy of the heart. Now we're going to work on learning how the heart actually functions. We're going to learn about heart physiology or cardiac physiology, everything from the way blood moves through the heart to how the heart pumps that blood, and even all the way down to the microscopic level, learning how ion exchange in the heart is going to actually help that heart to beat and how all those cells are going to beat all at once. So if you're ready to learn more about how the heart works, let's get started. So we're going to start our discussion of heart physiology talking about the electrophysiology of the heart. And to get started, let's review some vocabulary that's associated with any topic in electrophysiology. So you've probably already studied some muscle physiology and neurophysiology to understand how action potentials or electrical charges are propagated from cell to cell. So today we're going to be applying those same terms specifically to cardiac cells of the heart. So the first term we're going to review is what's called membrane potential. And recall that membrane refers to the plasma membrane of the cell. And so for today, we're going to be talking about the plasma membrane of the cardiac cells. Potential, anytime you see the term potential, think difference. It's talking about a difference in electrical charge between one side of that cell membrane and the other. So as long as those two charges aren't the same, you've set up a membrane potential. So membrane potential, charge difference across the membrane. Now, all cells have what's known as a resting membrane potential. In other words, what that charge difference is across the membrane when the cell is not actively firing an action potential. In the case of heart cells, depending on what kind of heart cells you're talking about, as we'll explain in a little bit, it can range from negative 60 millivolts to negative 90 millivolts. But in both cases, we're talking about a negative membrane potential for a resting membrane potential. Depolarization, that term is the same thing as firing off an action potential, an electrical charge. So in other words, we get a change from that resting membrane potential to something else that makes it less negative. So we're going to go from negative to positive voltage across that membrane when depolarization occurs. In other words, depolarization is when something's actually happening electrically. Repolarization is the opposite of depolarization. So whereas depolarization, you're getting less negative, you're becoming more positive. Repolarization, you're kind of coming down the hill, you're going from positive to more negative so that you can return to whatever that resting membrane potential was. And finally, hyperpolarization. So hyper means like more than or above, like lots. And so if in a state of hyperpolarization, you're going to go even more negative than what your normal, what we call threshold level is. So it's just going to go negative and then more negative. That's hyperpolarization. So we're going to apply these terms to the electrical conduction in the heart. So let's dive into this plasma membrane of our cardiac cells and look at the actual protein channels that are embedded in there that allow ions to go in or out and therefore creating an electrical current. So I'm going to use this little thing here as a protein just so I can illustrate for you what we mean by opening and closing of these protein channels. Now recall that proteins are made of amino acids. Some are positively charged, some are negatively charged. So when you change the shape of the protein, that's going to change the properties, which are going to allow certain ions in or not. So let's get started by talking about this sarcolemma. So recall that the sarcolemma is just another name for the plasma membrane of a muscle cell. And because we're dealing with cardiac cells, they are a type of muscle cell. They are striated, just like skeletal muscles, but not as striated as skeletal muscles. It's under a microscope, the striations will appear a little lighter. And these are kind of jagged, irregularly shaped cells, kind of look like a Y in some cases. But in this sarcolemma of these cardiac cells, we're going to have 4 different types of channels. And again, a channel is nothing more than a certain kind of protein. So a certain kind of protein. If you look at this animation here, you can kind of see what these channels would look like embedded in a little piece of plasma membrane here, and they allow things ions to go in or out, depending on what type of ion it is. And over here, we see just a schematic of the different types of channel proteins we're going to be talking about with regards to cardiac cells. So let's go over these different types. So one type is what's called a voltage-gated sodium channel. So Na+, remember, is a cation, a positively charged ion that dealing with sodium. So a sodium channel means that it's a protein that's going to allow sodium in or out of the cell. And so by voltage gated, we mean that what's going to trigger a conformational change of that protein, in other words, we call it the opening or the closing of the gate of the protein. Really all it means is that when a certain voltage hits that protein, it causes those amino acids to move around and change shape. And by changing shape, that will allow those sodium ions in or out if it's open, or keep them from going in or out if it's closed. So it's all about how that protein channel changes its conformational three-dimensional shape. So again, voltage-gated sodium channels means it will open or close, change shape, in response to a particular voltage value. So we got sodium channels, for example, right here. Now, normally sodium is more concentrated outside of the cell than it is inside when the cell is at rest. So at resting membrane potential, you're going to have a greater concentration of sodium ions than outside the cell in the extracellular fluid than you do inside the cell in the cytosol. And remember that in A&P, we talk a lot about gradients. So we've talked before about chemical gradients, so concentration gradients. In other words, where a chemical, or in this case a sodium ion, is more highly concentrated than it is on the other side of the membrane, it's going to go from an area where it's more concentrated to lesser. It's going to want to naturally diffuse the other way. But there are other kind of gradients as well. There's electrochemical gradients, so where the voltage is different on one side of the membrane than the other, and that's going to be the case when you have a whole bunch of sodiums outside the cell and not so many inside the cell. That means that the outside's more positively charged than the inside, and so the sodium wants to go inside the cell through this sodium channel to kind of balance everything out. That's the desire, if you will, to personify the cell of what it wants to do. So in addition to sodium channels, we're going to be talking about calcium ion channels, like you see here. And just like with sodium, at resting membrane potential, the concentration of calcium is going to be greater outside the cell than it is inside the cell. So calcium, when that channel is open, is going to want to go from the outside to the inside. Now, sodium channels are rapid closers. So when the sodium channel is exposed to a certain voltage, it will change shape really fast, it'll close, and no more sodium can come in. Calcium is a little different. The calcium channels are slower than sodium channels are, and they're time gated. So in other words, they're going to close more due to just time going on than they are a specific voltage. So just note that as a slight difference between calcium channels and sodium channels, because that's going to become an important factor for determining how action potentials are going to be propagated through the heart. Thirdly, we have potassium channels. And you can think of potassium channels as working in the opposite direction as do sodium and calcium channels. So just like the other two, they are going to change shape in response to a certain voltage. However, at resting membrane potential, more potassium is inside the cell than it is outside the cell. And once that channel, potassium is going to leave from inside the cell to outside the cell. So potassium wants to go from inside to outside, whereas with sodium and calcium, it wants to go from outside to inside. So potassium channels can be both voltage gated and ligand gated. So a ligand gated channel is one where another molecule, so for example a hormone, would dock right onto that protein, and that's what causes that conformational change to open and allow the ion to move. Voltage gated means it changes shape, it opens in response to a certain voltage value. And finally, we're going to also talk about things called non-selective cation channels, or HCN channels. So HCN channels would be, for example, illustrated by this pink channel here, where you're going to have cations. They could be any kind of cations: sodium, calcium, potassium, anything really, magnesium. Cations are ions that are positively charged, and in the case of the HCN channel, it's going to allow movement in both directions. So when that channel opens, when it changes conformational shape, then it is going to allow ions to go from inside to outside and from outside to inside. So they also, HCN channels are also voltage gated, so they're going to open or close in response to the voltage. And as you're going to see in a minute, they're only found in one type of cardiac cells, those being the pacemaker cells that set the rhythm for the heart. And the voltage that these guys are going to be activated by, when they're going to actually open, is when the cell is in what we call hyperpolarization, which you will recall means it's gone really negative, all the way back to its resting potential of negative 60 millivolts. So 4 types of channels we're going to talk about in cardiac physiology: voltage-gated sodium channels, calcium ion channels, which are time-gated, potassium channels, which are both ligand and voltage-gated, and non-selective cation channels. All right, let's get to it. So now let's break down the types of cells we're going to be talking about when we're talking about heart electrophysiology. So we already mentioned pacemaker cells. So pacemaker cells are groups of cells in the heart that are going to set the rhythm for the heart. They're going to determine how fast the heartbeats occur in that heart. Now, out of all the cells in the heart, they only make up 1% of the cardiac cells. So not many cells of the heart are pacemaker cells, but the ones that are very important play a very important role in the heart. So we're going to be talking about pacemaker action potentials, because how they occur is slightly different than how action potentials occur in the other types of cells we're going to talk about in a second. So these pacemaker action potentials are called pacemaker potentials, and their range of voltage is going to go from a resting membrane potential of negative 60 millivolts all the way up to a maximum positive potential of positive 10 millivolts. And we'll see how this happens and what happens in between. Now, when we're talking about protein channels for pacemaker cells, we're really not going to be talking about sodium channels. We're going to be talking about calcium channels, potassium channels, and HCN channels. So pacemaker cells are the only ones that are going to really use these HCN channels. You'll see in a second that the other type of cell, cardiac cells, contractile cells, are going to use a different type of channel instead of HCN. So take home here, pacemaker cells, negative 60 to positive 10 millivolts, calcium, potassium, and HCN channels. Contractile cardiac cells, these are the cells that actually do the contracting of the heart to make systole, to make the contractions. This is all the rest of the cells, so it's going to be about 90% of the cells in the heart are contractile cardiac cells. And what's going to trigger their action potentials are the action potentials you just made from the pacemaker cells. So once the action potential, the electricity, goes through the pacemaker cells, they are then going to be sent on to the contractile cardiac cells, where those action potentials will spread through those contractile cells, and all those cells will contract simultaneously. And if you look at this picture right here, you can actually see those striations of the cardiac muscle cell. And, sliding filament theory, just like you learned for skeletal muscle, when you see those myosin and actin fibers do their thing, and that's what's actually making the contraction of these cardiac cells. They all happen simultaneously if everything's going right, and that makes the heart contract. So either the atria or the ventricles contract simultaneously. And it's really amazing how this happens. But it's all triggered, and the pace of it is set by those pacemaker cells. So notice a difference here between the contractile cardiac cells and the cells of the pacemaker cells. The minimum voltage, or the resting membrane potential, is different between these two. So in pacemaker cells, resting membrane potential is negative 60 millivolts. In contractile cardiac cells, it's negative 85 millivolts. And the maximum is positive 20, where it was positive 10 in the pacemaker cells. So that's an important thing to note, is that the range of voltage is different between the pacemakers and the contractile cells. And as just mentioned, the channels that are used by contractile cells are slightly different in composition compared to the pacemaker. So whereas pacemaker was using calcium, potassium, and HCN channels, contractile cells use sodium and calcium and potassium channels. So no HCN channels for contractile cells, and instead they use sodium ion channels. But both use calcium and potassium. And what's cool is, as we mentioned, these cells are going to beat simultaneously together. It's really amazing. You can put contractile cells from different individuals into a petri dish under the right conditions, and they'll actually start beating together. It's really amazing how this happens, all due to electrical gradients and that electricity going through these cells, the gap junctions that at the intercalated discs that allow these cells to communicate with each other. But because they can do that, they are considered to be independent of the nervous system. Now, the nervous system, the sympathetic and parasympathetic branches, can influence the pacemaker cells in terms of how rapidly they fire. But overall, these cells operate independently of the nervous system. They're going to beat together no matter what the nervous system's doing. So in that sense, they have autorhythmicity. Auto meaning self, so rhythmicity, the rhythm. So they set their own rhythm independent of the nervous system. So very cool. And here you can see some heart cells here stained with green fluorescent protein. So let's start talking about these pacemaker cells. So the pacemaker cells of the heart occur in 3 overall populations physically within the heart. And you can kind of see these in these diagrams. So you're going to have 2 of these populations occurring in the right atrium, sort of the posterior side. You can see one is kind of right near where the superior vena cava empties into, and the other one is kind of right near that valve that divides the atrium from the ventricle on the right side. And then the third population is going to be found through these fibers or branches that then branch around over here. And you can see that first one also branches over to the left atrium as well. So these fibers that are going to conduct the electricity from these pacemaker cells, in this picture, you can actually kind of see how they're laid out, which is really cool. So let's talk about these populations. So first, we have the sinoatrial node. Again, that's this first one that you see here that also branches out. So the sinoatrial node, or SA node, superior right atrium, and this is really, if all's well and there's nothing wrong with it, it's going to be the one that really sets the rhythm for the heart. It has the fastest rate of depolarization compared to the other populations of cells, pacemaker cells. So anywhere from 60 to 70 action potentials per minute. In other words, it's setting that rate for heartbeats. And it's under the influence of the sympathetic and parasympathetic nervous systems. So we'll be talking about this later, about how not just neuron firings, but also hormones can play a role in telling that SA node how fast to fire those action potentials. So that's the sinoatrial node. So it's going to send out action potentials down to the next population called the atrioventricular node, or AV node. And it's also going to send them all the way over to the left atrium. And so you can kind of watch this on this animation right here. So you can see the action potential from the SA node going on down to the next one, the AV node, as well as over to the left atrium. So atrioventricular node, or AV node, this is in the inferior right atrium, and you can see that it's slower. So it's going to fire action potentials more slowly than does the SA node, 40 to 50 action potentials per minute versus the 60 or 70 for the SA node. Now, it's interesting to note that if something's wrong with the SA node, it's blocked, there's something's wrong, the AV node can take over, but it's going to mean that the pace of the heart is slowed down a bit because it's a slower node. Part of the reason for that is there's fibers around the AV node that don't conduct electricity or don't conduct it very well. And that's called the AV node stoppage area, or where it's going to pause. Basically, everything kind of pauses when it gets to the AV node. It's going to slow everything down. And then finally, our third population of pacemaker cells are what's called the Purkinje fiber system. And this is what you see in the animation where the action potentials leave the AV node, travel down that interventricular septum through what are called bundle branches. So we have a left and right bundle branch, and then they wrap around, the action potentials wrap around into these Purkinje fibers, and you can see those here, and spread out to the ventricles, where they will then come in contact with the ventricular contractile cells to generate those heartbeats. So Purkinje fibers are sometimes called atypical pacemakers. And again, they occur in 3 bundles. So we have the AV bundle, which is occurring right at that interatrial septum. And then the right and left bundle branches, which go down either side of the interventricular septum. And then the terminal branches are the Purkinje fibers that where the action potential is going from the Purkinje fibers to the end where they make contact with the ventricular contractile cells. Now, out of all 3 populations, the Purkinje fiber system puts action potentials through the slowest. So we're talking about 20 action potentials per minute compared to the 40 to 50 for the AV node and the 60 to 70 for the SA node. Now, the question might be, well, what if there's something wrong with the SA node and the AV node? Can the individual survive by just having the Purkinje fiber system set the rhythm of the heart? And the answer is, for humans, probably a little while, but probably not extensively or for very long, because 20 action potentials a minute really is not enough to have the circulation of the blood through the body happen that you need, at least to be sustained for very long. All right, you guys, so let's dive in and figure out what exactly is going on with these channel proteins in the sarcolemma and how does that look on a graph. So this is a difficult concept for a lot of people, but we're going to break it down, and I've even added in some homemade animations to the slide that I hope are going to help you to understand this. So we're going to start talking about those pacemaker cell populations. And what were those 3 pacemaker cell populations? That's right, you have your sinoatrial node in the right atrium, you have the AV or atrioventricular node in the inferior right atrium, and then you have those and then you have the Purkinje fiber system, which is going to consist of the AV bundle, the right and left bundle branches, and the Purkinje fibers themselves ending in the terminal branches. So let's figure out how an action potential is propagated through a pacemaker cell. So let's go. So this is going to occur in a series of steps. The first step is going to be what's called the slow depolarization phase. And remember, depolarization, we're going from a negative voltage at the resting membrane potential up. So we're going to become more positive or less negative. And this is going to involve those HCN channels. And I have that illustrated here. So this is our plasma membrane of a cardiac cell, and here's the HCN protein channel embedded in it. And recall that pacemaker cells are going to be the only ones that are using these HCN channels. The contractile cells do not use HCN channels to fire an action potential. So in this case, we're going to have cations. And remember, cations are just any positively charged ion. But in this case, let's talk about sodium and potassium ions. And when an action potential starts from this SA node, it's going to continue to make a slow depolarization until we go from our resting potential of negative 60 millivolts, remember that's the resting potential for pacemaker cells, and becomes more positive until it reaches threshold, which in the case of pacemaker cells is negative 40 millivolts. So how is this going to happen? Remember that these potentials deal with a difference in charge on either side of the membrane. And so what's going to happen in this case is we're going to have sodium ions, illustrated in pink here, being more concentrated at resting potential outside the cell than inside the cell. And in contrast, potassium ions, which are also cations, are also positively charged, are more concentrated at rest inside the cell than they are outside. So given these electrochemical gradients we've been talking about and concentration gradients, the sodium wants to go from outside to in, and the potassium wants to go from inside to out. But because there's overall more sodium outside, more cations outside than there is inside, potassium ions inside, it's going to make the overall change in charge across the membrane more positive inside the cell because we're bringing more cations in than we are pushing them out. So let's see how this happens. Okay, did you see that? I'm going to go in reverse. Watch what happens to these sodium and potassium ions at the HCN channel. Okay, so you see that? More cations, in this case sodium, are moving inside than the cations are moving out. So we get an overall increase in positive charge, slow depolarization happening inside the cell as a result of that exchange of cations where you end up with more coming in than you have going out. So now let's see how that translates to this graph. So we have on the y-axis membrane potential in millivolts, and on the x-axis we have time going from 0 on up in milliseconds. And then I've labeled here at -40, that's our threshold membrane potential for pacemaker cells. And remember that we're going to start at resting membrane potential at -60 millivolts. And so these HCN channels will open conformational change in response to that voltage hitting -60 millivolts, so hitting resting potential. So once -60 is reached, the conformational change happens in that protein. It opens, and that allows that exchange of cations, overall making inside the cell more positive. And so the graph will start off looking like this. So you can see how we go from -60 slowly on up, depolarizing to a less negative or a more positive voltage, which is -40 millivolts. Okay, so that's step one, slow depolarization phase. In step two, we're going to bring in those calcium ion channels. And recall that we said, just like with sodium, calcium at resting potential is going to be more concentrated outside the cell than it is in. So that calcium, by the electrochemical gradient and concentration gradient, those calcium ions want to go from an area where they're greater concentrated outside the cell to where they're less concentrated inside the cell. And calcium, in addition to just being time gated, where it opens and closes slowly, it also can be voltage gated. And so once that voltage has hit -40 threshold as a result of what happened with the HCN channel, that's going to cause a conformational change in the calcium ion channel, open it up, and those calcium ions are going to start flooding inside the cell. So now we're, calcium is 2+, so it's a positively charged cation, and that is going to bring all these positive charges from the outside to inside the cell really fast. It's going to bring a lot of positive charge in there, and that's going to make the positive charge of this membrane, that voltage, is going to shoot up all the way to +10. It's going to get really positively charged inside that cell. And that is what we call full depolarization. So this is the full depolarization phase. We're going to go from the threshold voltage of -40 that we got as a result of what happened with the HCN channels, and now it's going to boom, shoot up all the way to +10. So we're going to reach our maximum potential at +10. So let's watch how this happens. Watch the calcium channel. Once -40 is reached, this voltage gated channel is triggered, and watch what happens. There those calcium ions go inside the cell, and so now the graph, as a result, so it opened at -40, and now, boom, it's going to shoot all the way up to +10. I'll move my face out of the way here a little bit so you can see a little bit better. So it's going all the way up to +10. Well, what goes up must come down, right? And so now we have to enter the third phase, which is the repolarization phase, where we're going to repolarize the membrane. In other words, we are going to come back down. We're going to get more negative until initially we get to threshold. So we're going to now start to close our calcium channels. Remember, in addition to being triggered by voltages, calcium channels are time gated. So they just take some time to close. They're kind of lazy. They're just kind of like, okay, I'm open, and now I guess I'm going to change shape and close. And that prevents any more calcium from flooding in. And at the same time, when we reached positive 10, that triggered for these potassium ion channels to open. Because remember, these are voltage-gated potassium channels in addition to being ligand-gated. And as soon as those potassium channels open, potassium is now going to flood from where it's more highly concentrated to where it's less concentrated. So in this case, from inside the cell to outside. There's a lot more potassium at rest inside the cell than there is outside the cell. And so that potassium is going to go through the potassium channel to the outside. So let's watch that happen. Okay, so they're all moving out. Well, when you're moving cations out of an area, you're losing positive charge. Well, the same thing as of losing positive charge is making it more negative. And that's, recall what repolarization is. So when we're moving those potassium ions out, we are losing positive charge, and therefore the inside of the cell, inside of the membrane, is going to become more negative. It's going to repolarize, and in fact, it's going to repolarize all the way back to threshold, which was negative 40 millivolts. So let's watch that happen. Okay, so it's going to go from positive 10 down to threshold of negative 40. So we're almost done, but there's still another step because we're not at resting membrane potential yet. Remember, for pacemaker cells, resting membrane potential is negative 60 millivolts. So we enter the fourth phase, which is the minimum potential phase. The minimum potential, meaning resting membrane potential of negative 60 in the case of these pacemaker cells. And so this is going to happen because those potassium channels haven't closed yet. They're still open. Potassium continues to leak out. We continue to lose positive charge, and at this point we're going to hyperpolarize, which means, remember, hyperpolarization, you're going more negative, way down into the basement below threshold. And so at this point, the graph is going to go all the way back down to negative 60 millivolts, which is the minimum potential phase or the resting potential. And remember that negative 60 millivolts is what triggers the opening of the HCN channels. So that starts another cycle, right? So it's going to repeat the cycle and everything's going to happen all over again. So heart beating is cyclical, right? So we're going to start a new heartbeat cycle. So now you understand how action potentials go through pacemaker cells. But after they've left the pacemaker cells, they are going to then go down the ventricles and meet up with ventricular contractile cells to spread that action potential from contractile cell to contractile cell, so ultimately the ventricles can contract. So how does this happen? Now, one of the things you're going to realize is there are both similarities and differences between how action potentials are propagated through pacemaker cells and how they're propagated through contractile cells. So I'll try to point out the differences and similarities as we go along. So the first phase for contractile cell action potentials is what's called the rapid depolarization phase. So recall that depolarization means you're going from negative, in this case the negative resting potential of negative 85 millivolts, on up to become more positive. Now, unlike in pacemaker cells, where it started off with a gradual or a slow depolarization to threshold, in the case of contractile cells, this depolarization is going to be very fast indeed. It's going to go all the way from negative 85 millivolts on up, straight up to positive 20 millivolts. So again, notice that the range of membrane potential is much greater in contractile cells than it is in pacemakers. Pacemakers went from a resting potential of negative 60 millivolts up to a maximum positive action potential of positive 10 millivolts. In contractile cells, we're going from negative 85 up to positive 20. So huge positive increase during this rapid depolarization phase. Now the question is why? Why does it happen so much faster here than it does in pacemaker cells? Well, the key is those sodium ion channels that are embedded in the membrane. So recall that pacemaker action potentials depended on HCN channels as well as calcium and potassium. Well, contractile cells do not use HCN. They use sodium ion channels as well as calcium and potassium channels. So when a sodium channel is involved and it has its conformational change, it opens up, those sodium ions, which are more concentrated outside the cell than in, they are going to just rush right in through that sodium ion channel to the inside of the cell, and that's going to all at once make the inside of the cell much more positive than it was before. So that rushing in is going to be what generates that full rapid depolarization up to positive 20. So let's see how this happens. So watch these little sodium ions go through the sodium channel into the inside of the cell. So there they go. Boom. So how that looks on the graph, once the sodium enters, we're going to go from negative 85 millivolts at resting potential to at time 0 going straight up to positive 20. So it's going to look like this. So negative 85 straight up to positive 20 because we're just flooding positive charges, cations, into the inside of the cell. So that's the first step. Second step, initial repolarization phase. So remember that anything that goes up has to come back down. But in contractile cell repolarization, it's going to start off happening slowly. We're going to slowly decrease from positive 20 down to 0 millivolts. And how is this going to happen? Well, we know we're starting at positive 20. We got all these sodium ions in there now. But very slowly, you're going to get leakage of potassium ions going through that potassium channel from where they're more concentrated inside the cell to where they're less concentrated outside the cell. But in this case, the potassium channel is still closed. It has not opened. It has not opened its gates. So we're not going to get a flood of potassium going to the outside. We're just going to get a few leaks happening while that channel is still closed. So in other words, we're slowly leaking away positive charge from the inside of the cell, and we're sending it to the outside. So the inside of the cell is going to slowly start becoming less positive, or the reverse of that, more negative. So let's watch that happen. There we go. Just a few of these guys are leaking slowly out. So you're losing some positive charge, and therefore the graph is going to slightly decrease down to 0. So, again, potassium channel here is still closed, but potassium channels are a leaky channel. So that means like it's closed, but it's not tightly closed. There are still leaks and the potassium still gets out. So that's the second phase, initial repolarization phase. What happens next? Well, what happens next is very interesting and very different from what happened with the pacemaker cells. We're actually going to go through what's called a plateau phase where not anything is happening. Remember that we just got down to 0 millivolts, and during this plateau phase, it's going to stay at 0 millivolts for a while, producing what's called a refractory period where nothing can happen. Why does this happen? Well, you've been having this leakage of potassium going to the outside, but now when you get to 0, that calcium channel is going to open. And when the calcium channel opens, all these calcium cations from outside the cell are going to rush inside the cell and make it, it's going to make it positive very fast. So why does it stay at 0? Well, remember that potassium channel? It's still leaking potassium. So even though you're kind of putting some more positive charges back, you're still losing positive charge by losing potassium. And so it's just going to bob along 0 degrees, or sorry, 0. So it's just going to bob along at 0 millivolts for quite a while. And so the graph, after we continue to leak potassiums out while we're getting calciums in, is going to just kind of bob along at 0 millivolts. So that is what's called our refractory period. That's when you can't have any more firing during that time period. But once these calcium channels close, and remember that calcium channels are time gated as well. So over time, they just naturally go back to their former shape. They close on their own. And when that happens, we also get an opening of the potassium channels. And therefore, it's no longer leaking of potassium, it's rushing of potassium out. So calciums come in, it's already closed now, no more calciums coming in. And so now the potassium is going to open, the potassium channel, and all these potassiums are going to go ahead and rush on out. That's going to drive that membrane potential way down very fast at this point because, you've just lost a lot of positive charge from the inside all at once. So all they go, and now our graph is just going to go all the way down to threshold, and because this potassium channel is remaining open, potassiums continue to be lost to the environment, and so we're going to hyperpolarize back down to our resting potential of negative 85 millivolts. So this ends up being what that graph looks like for how contractile cell action potentials occur. So again, initially rapid depolarization from negative 85 to 20, positive 20. Then initial repolarization, slight decline to 0. Then that gets held during that refractory period. And then suddenly after the plateau phase, you get rapid repolarization phase where we're going to go all the way down to negative 85. So this refractory period is key. It's not occurring in the pacemaker cells, but it's what allows us to continue to have some difference between atrial and ventricular contractions, so that your heart is essentially keeping its pace and doing what it needs to do. So now you know how an action potential propagates through contractile cells. Now let's dive a little bit inside the cell and figure out what happens when that action potential goes through the cell. How does that affect the myosin and actin filaments in there that actually lead to contractile cell contraction? And of course, when you put the contractions of all these contractile cells together, you get the whole heart contracting. So recall back to skeletal muscle contraction. This is really going to be very similar, almost identical, with some slight differences. You might remember that the sliding filament theory of skeletal muscle contraction was where myosin and actin filaments slide past each other due to what's called a cross-bridge cycle, where myosin heads will bind to actin filaments when calcium binds to a protein called troponin. So this whole phenomenon is called the excitation contraction coupling phenomenon. So just like with skeletal muscle cells, when that action potential reaches those contractile cells and propagates through the cells, it's going to do so by first propagating through the sarcolemma. And recall that the sarcolemma is just another name for the plasma membrane of any kind of muscle cell, in this case, cardiac muscle cells, specifically contractile cardiac muscle cells. Now, also like with skeletal muscles, once that action potential starts going through the sarcolemma, that sarcolemma kind of dives down, forming a T shape, and we call that a T-tubule. So that action potential is going to go ahead and go down that T-tubule, and you might recall that calcium comes into play during this process. However, here's a slight distinction between what happens in contractile cells versus what happens in skeletal muscle cells. So in skeletal muscle cells, most of the calcium is being generated from the sarcoplasmic reticulum, which is just a muscle cell's version of the endoplasmic reticulum. And in skeletal muscle cells, very little of that calcium is coming from outside the cell. Most of it's generated internally in this sarcoplasmic reticulum. In contractile cells, however, we're going to heavily rely on all that calcium that's in the extracellular fluid. And that's because there's really not that much generated by the sarcoplasmic reticulum of contractile cells, because there's actually not that much sarcoplasmic reticulum to begin with, and it's not connected that well to T-tubules compared to skeletal muscle cells. So instead, what's going to happen is we are going to get a positive feedback loop. We're going to take that calcium that's already in the extracellular matrix that we've been talking about all this time. It's going to diffuse into the cell, and as it goes through that T-tubule, it is going to basically tell the sarcoplasmic reticulum to release more calcium. So it's going to stimulate sarcoplasmic reticulum increase in terms of calcium release. And so this idea that in contractile cells, that calcium from the outside is going to generate more calcium release on the inside, that is called the calcium ion-induced calcium ion release. That is a mouthful. Calcium ion-induced calcium ion release. That just refers to the positive feedback loop that's generated by calcium from the outside, from the extracellular fluid, telling the sarcoplasmic reticulum to release more calcium. And so that positive feedback loop is going to generate enough calcium to get these filaments, the thick and thin filaments, to slide past each other, generating a nice strong contraction inside those contractile cells. And again, you put that together, all that happening in the contractile cells, and that's how you're going to get heart contraction. So taking a little look here, just remember this is called the cross-bridge cycle, where the myosin heads are binding to the actin filaments as a result of the calcium binding to troponin, kind of causing a conformational shift that opens up a space, basically exposes the actin filaments to the myosin head. And then just like rowers, on a canoe, it binds and it pulls back. That's that cross bridge cycle. And that's pulling those filaments tighter, closer together. And that is a contraction at the cellular level. So as we get started with talking about the mechanical physiology of the heart, let's go over some basic vocabulary that we're going to need to know, and also talk about heart sounds that you can listen to with a stethoscope. So first of all, let's talk about the difference between systole and diastole. So systole refers to the contraction of any of the four chambers of the heart. So in other words, contraction of the heart chambers. So that's called systole. On the EKG that you're about to learn about, you'll learn where, for example, ventricular systole is occurring. That's the main one that we're kind of looking at when we're looking at these EKGs. Diastole would be the opposite. So in diastole, we have relaxation of the heart chambers. So this would be when those chambers are filling with blood, as we'll talk about more in a little bit. So now let's talk about those heart sounds. So all of us have at some point been around a stethoscope. Either maybe you used a stethoscope, but more likely you were probably a patient and had a stethoscope used on you. So the purpose of the stethoscope is to listen to these heart sounds and make sure that everything is functioning normally. So there are two main heart sounds that you listen to with a stethoscope. These are called the S1 and the S2 heart sounds, also known as lub for S1 and dub for S2, because when you hear a heartbeat, it sounds like lub dub, lub dub, lub dub, lub dub, right? What these correlate to is the closing of the valve. So if you think back to the anatomy of the heart that you learned about, you have two AV valves, left and right, also called atrioventricular valves, or on the left side, it's called the mitral valve, and on the right side, it can also be called the tricuspid valve. And so when you hear that lub sound using the stethoscope, that's correlating to the closure of those AV valves that separate the atria from the ventricles. So you can listen to this by placing the stethoscope in the appropriate place. So in terms of the AV valves, we're going to be interested in the mitral and the tricuspid valves. So if you figure that the sternum goes straight down here, the tricuspid valve, to listen to its sound, you're really, the sound of it closing, you want to stick your stethoscope basically just to the left of the sternum at about the fourth intercostal space. So fourth intercostal space means between the fourth rib and the fifth rib. And you want to listen to it just to the left of the sternum, and that will allow you to hear the S1 sound regarding the closing of the tricuspid valve. To hear the closing of the mitral valve, it's actually better to place the bell of the stethoscope at the fifth intercostal space on the left side, mid-clavicular. That means if you imagine this is the clavicle right here, halfway, if you were to draw an imaginary line down all the way to the fifth intercostal space, that's where you would place this. It's kind of near the apex of the heart, and that will allow you the best place to hear the closing of the mitral valve. Now for the S2, the dub, that's the closing of the semilunar valves. So the aortic semilunar valve and the pulmonary semilunar valve. Those are best listened to at the second intercostal space between the second rib and the third rib. So to hear the aortic semilunar valve closing, you'd put it on the right side of the sternum at the second intercostal space. And to hear the pulmonary one, you would put that on the left side of the sternum at the second intercostal space. And these S2 sounds tend to be a little quieter than are the S1 sounds. Now, there are other sounds that you could hear called S3 and S4. Some people have those naturally, and others it could signal a pathology. So, those are other sounds that you can listen for as well, but this is where you would put your stethoscope to listen to the S1 and S2 heart sounds, which we're going to be discussing in more detail as we talk about the mechanical physiology of the heart. It is time now to talk about electrocardiograms, better known as ECGs or EKGs. They're used interchangeably. So this is just a measurement of the electrical conductivity of your heart, and it's represented in a graph. So in other words, it's a graphical representation of all action potentials in the contractile cells. And really what it's doing is not measuring how much electricity is generated or lost. It is measuring the change in electrical activity that's occurring at any one moment during a heart cycle, a cardiac cycle. So it is represented, these action potentials, on a graph by waves, as you can kind of see down here. And so what we're going to be doing in the next couple slides is breaking down an ECG so that you can identify exactly what wave is what and what it means for the stage you're at during the cardiac cycle. So you can measure a person's electrical activity of their heart using these electrodes that are hooked up to a machine so that you can get your electrocardiogram. And these are going to be placed on the chest, and they can also be placed on the extremities. So you're going to have 6 electrodes along the chest, and the first 2 are going to go between the 4th rib and the 5th rib. So this is called the 4th intercostal space. So if you remember intercostal muscles, you just remember that those are the ones around the ribs. So the 4th intercostal space is between the 4th and 5th ribs here. So you can see those there. You can see that one is going to be placed closer to the 5th rib on the left side, sort of right near the apex of the heart, and then 3 more kind of going down this way, 1 on each arm over here, and you can put 1 on each leg, and if you want, you can even put 1 on each side of the ankle, kind of near the ankle. So anyway, these are the standard places to put these electrodes because those are areas where you're going to be able to best measure the electrical activity of the heart. So there's 5 waves we're going to be talking about, and we'll break those down in a second, but those are going to show whether we're in depolarization or repolarization of the atria or the ventricles, or if you're not in one of those, what else is going on. So again, overall, it's showing you the change in electrical activity, not whether that change is positive or negative. You're also going to be able to look at intervals, which are periods of time on the graph that contain at least one wave. And you're also going to be able to look at segments, which is areas of the graph where there are no waves. And so you can look at these. Are they normal? Are they abnormal? Which might help to figure out if there's a pathology going on. So let's break these down and learn about these waves. Okay, so we're ready to talk about those 5 waves of an EKG. So let's get started with the first wave here called the P wave. Now, it should be noted that this little flat line right before you get to the P wave is when the SA node is actually depolarizing. So the sinoatrial node, SA node, remember, is in the upper right posterior atrium. And so when that depolarizes, which of course starts the whole thing, right? That produces a flat line, and then you get the depolarization of the atria themselves, which is happening during that P wave. Now, next, you have a flat line, and then it goes down to what we call the QRS complex. So it dips down to Q, way up to R, and then way down to S. That together is the QRS complex. So it's very large. And also, you're going to have the repolarization of the atria occurring during this time, but this big wave, which represents depolarization of the ventricles, is going to mask what would be produced by the repolarization of the atria. So what we're seeing here with QRS is the depolarization of the ventricles. So P, depolarization of atria, QRS, depolarization of the ventricles. We're then going to get another flat line, And another bump, but this is a bigger bump than we had for P. This is called the T wave. And this T wave is going to represent repolarization of the ventricles. So when the ventricles are relaxing and we're coming back down from that really positive membrane potential way down to the negative minimum membrane potential. So that's occurring during this T wave. So let's get a deeper dive of this EKG here. But at this point, you know that you have a P wave representing atrial depolarization, a QRS complex representing ventricular depolarization, and a T wave representing ventricular repolarization. So now let's take a deeper dive into an EKG tracing. And recall that we talked about intervals and segments. Intervals have at least one wave in them. Segments have no waves. So the first interval we're going to talk about is the RR wave. And what that means is from R wave to R wave. So you're looking at a full cardiac cycle there. And we're going to use this to measure heart rate. And what it's really doing is looking at the total action potential through the heart. So it's kind of tracing that action potential all the way through the heart during one cardiac cycle so you can determine the heart rate. Another interval that you want to look at is what's called the PR interval. And you can see that here. And ironically, it doesn't clearly involve R because it's going to be from right before the P segment starts to essentially the Q segment, or where that QRS complex starts. So this is going to include the action potential in the SA node, as well as through the atria and then through the ventricles, or to the ventricles. So it's looking at the spread of that action potential from where it starts in the SA node through the atria and down to the ventricles. And it's going to include that AV node delay, which you'll recall, things slow down when it gets to the AV node because the fibers don't conduct electricity as well anyway. So that was the PR interval. Our QT interval is kind of what it sounds like. It's going to start at the Q wave and continue all the way until right at the end of the T wave. And so that's going to allow you to track action potentials through all those ventricular cells. And finally, we have what's called the ST segment. And this is going to go from the end of the S wave to the beginning of the T wave. And you can see it's nice and flat because there's no change in electrical conductivity going on because you're in that plateau phase. So recall that graph from before where you have that refractory period, and that was the plateau phase of the ventricles. So that's going to be reflected in this ST segment. You shouldn't have anything except a flat line there. If you do get something besides a flat line, that could signal some pathology such as an infarction or a heart attack. So up to now, we've been talking about normal ECGs. But ECGs are often used to try to detect if there's any abnormalities going on with the heart. So let's talk a little bit about some of these common abnormalities that are often seen on EKGs. So first, let's talk about dysrhythmias or arrhythmias. And there's really three ways that these can happen. So first, you could have a disturbance in the electrical rhythm of the heart. So in other words, it's not going at the normal pace that you should have it go at. And there's really two categories for this. So one, maybe the heart rate is too slow compared to what would be considered normal. And this is called bradycardia. So bradycardia, slow heart rate. And this occurs when the heart rate is less than 60 beats per minute. On the opposite end, your heart rate could be too fast, and that's called tachycardia. So tachycardia, fast heart rate greater than 100 beats per minute. So that's one way you can get this dysrhythmia. Another way is that you have some kind of disturbance in the conduction pathways. So this could be caused because there's some kind of heart block in the nodes or the bundles. So the SA node, the AV node, or any of those bundles leading down to the Purkinje fibers. And so if you're looking at an ECG that is of somebody with some of these disturbance and conduction pathways, you're going to notice that you get a lot of extra P waves. And so you can see in this EKG down here, this is a first degree AV block ECG. So in other words, this person is having some kind of blockage in the AV node, and notice that you get, like these extra P waves going on. Now, a third way is through fibrillation. And this is when the heart just is doing weird things. It's not following that normal, regular pattern of heartbeats that it's supposed to. And you can kind of see an example of this here would be a normal heart that we've been talking about, where the action potential is generated from the SA node, travels the AV on down, and, makes the heart contract the way it's supposed to. In this example, it's atrial fibrillation, which is also called AFib. And you can see that the electrical activity is just kind of going haywire in the atria over there. So in other words, when fibrillation is going on, there's some kind of chaotic electrical activity going on. You might have some parts depolarizing while other parts are repolarizing. And this could happen in the atria or in the ventricles. So in atrial fibrillation, you get what's called irregularly irregular rhythm on that ECG. In other words, the rhythm is irregular, but even the irregularity doesn't follow any particular pattern. It itself is irregular. So they literally call that irregularly irregular. And so what you're going to see on the EKG is no P waves. And so if you look at this picture of somebody who's in atrial fibrillation here, you can see that there's no P waves. The P waves were kind of just like lost or erased. Now, people can usually survive with these, especially if they get treatment. So it's not always life-threatening, but it is something that would need to get watched. But you can contrast that to ventricular fibrillation, which is what we see here. And this is chaotic electrical activity going on in the ventricles, and it is immediate life-threatening emergency. So this is where you would need a defibrillator, where they put that on the chest and boom, and that basically is going to immediately depolarize the ventricles and reset the heart. So that is when a person is in ventricular fibrillation. Now, another condition that can happen producing an abnormal EKG is what we call asystole. And it's exactly what it sounds like. So A means not, systole means being in systole or having contraction. So this is also called flatlining. So in other words, there's nothing going on in the heart. It is flatlined. And so obviously if someone is going through asystole, if they're flatlining, you need CPR. Usually they're administered drugs like epinephrine and atropine, and that is, hopefully going to restart that electrical activity, and so they're not lying anymore. Okay, we are ready to talk about the mechanical physiology of the heart, and we're going to go from heartbeat to heartbeat. In other words, one cardiac cycle. So a cardiac cycle consists of what's going on in each chamber in one full cycle. So that means one round of diastole in the chamber. That means the relaxation of that chamber and the filling of blood. And one round of systole, which is where the chamber is going to contract and eventually eject the blood. So those two together represent one cardiac cycle. Now recall that when an action potential is propagated from the SA node down to the AV node, there will then be a delay around that AV node due to the types of fibers that are there that don't conduct electricity well. And that's a good thing because we want that delay so that our atria can contract at a different time than the ventricles contract. So let's take this cardiac cycle and we're going to divide it into 4 main phases. And to me, the easiest way to learn these phases is just to kind of close your eyes. By now, you know how blood flows through the heart, and just kind of imagine what's happening with that blood flow in your mind. And then you can easily figure out what stage you're in, what phase of the cardiac cycle based on that. So let's start off with the first phase of the cardiac cycle, and this is called the ventricular filling phase. And it's just what it sounds like. The ventricles are filling. And of course, what are they filling with? They're filling with blood. And so this is when, the atria have already filled and that blood is now getting heavy. It's putting pressure on the walls and the AV valves. And so eventually that blood is going to drain from the atria into the ventricles. And this really has a lot to do with pressure. So you've already learned about gradients. Gradients are just where there's more of something on one side than there is on the other. So we've talked before about concentration gradients and electrochemical gradients. Well, in this case, when we're talking about the cardiac cycle, it's useful to talk in terms of pressure gradients. And so what you have to realize is that when something is filling with blood, that blood is heavy and it's putting pressure on the walls of that chamber. It's putting pressure on the valves that are associated with that chamber. And the pressure in that chamber, when it gets to be greater than the pressure in which it wants to drain the blood into, that blood's going to go from where the pressure is greater to where the pressure's lower. So you've set up a pressure gradient. And so during the ventricular filling phase, because all the blood is pooled in the atria, the pressure is greater in the atria than it is in the ventricles. So that lower pressure in the ventricles compared to the atria makes that blood want to go from the atria into the ventricles. Now, not only is the pressure greater in the atria than it is the ventricles, but it's also greater inside the aorta if you're talking about the left side of the heart, or the pulmonary trunk if you're talking about the right side of the heart. So in both of these cases, the pressure in the ventricles is less than that of the atria and of the great vessels. And so that blood wants to go into the ventricles where the pressure is less. And so because of this pressure gradient, this difference, those AV valves are going to be open. You could think of it as that pressure of the blood on those valves makes them open, allowing the blood to drain in. However, at this point during ventricular filling, the semilunar valves that are inside the aorta and the pulmonary trunk, those are still closed, because even though, the AV valves are open because of that high pressure in the atria compared to the ventricles, there's not enough pressure built up yet in the ventricles to warrant the opening of those SL valves, the semilunar valves. So those are being closed at this point. Now, with regards to how blood drains from the atria into the ventricles, it's worth noting that 80% of it is passive. That blood is just going from where it's more concentrated to where it's less. But 20% of it will actually come from the blood that's ejected during atrial contraction. So those atria are going to, just let most of that blood flow through, 80%, and that last little bit that's left, you're going to contract it and squirt it out, eject it into the ventricles. So all of that is happening during the ventricular filling phase. And this correlates, if you look real closely here, we have an EKG, and you'll notice all of that happening is corresponding to the P wave on an EKG, because remember, that's where the atria are depolarizing. So all that's going on. So start to keep track of how what's going on mechanically in this cardiac cycle is corresponding to the electrical changes that are going on an EKG. We're going to be putting these concepts together in one big graph pretty soon, so stay tuned. Okay, I think at this point we're ready to go on to the second phase of the cardiac cycle, and this is called the isovolumetric contraction phase. So let's break that down. Iso means same, volumetric refers to the volume. So we're going to have the same volume. We're not changing volumes. And this is also a contraction phase. So we're going to be dealing with contraction of the ventricles. So let's, just imagine where we've come from so far. We went from having the blood pulled up in the atrium to going through those open AV valves and draining into the ventricles, and finally the rest getting contracted and squirted into the ventricles. So now in phase 2, the isovolumetric contraction phase, we have filled up those ventricles. And so the pressure in those ventricles is increased greatly, because it's now filled with blood, and that blood's putting pressure on the walls of that ventricle. And as that pressure has increased, it's put pressure against those AV valves and closed those, and that prevents backflow of blood into the atria. So it's closed those, but now the pressure has increased so much in the ventricles that the pressure in the ventricles now is greater than the pressure inside the aorta and the pulmonary trunk. And remember, once the pressure is greater on one side than the other, it wants to balance out. So that pressure is then going to force the valves in the semilunar valves that are in the aorta and the pulmonary trunk to open. So We've increased the volume in the ventricles, put pressure on the walls, put pressure against those semilunar valves. And when that pressure is greater in the ventricles than the semilunar valves, or than greater than it is in those great vessels, we're going to push those semilunar valves open, and that starts those ventricles to contract. They're going to start contracting because there's so much blood in there, so much pressure. It's like a volcano. It wants to erupt. It's going to try to contract and get rid of that blood. So we're starting to see the beginning of contraction of those ventricles, even though the volume of blood hasn't changed yet because we haven't ejected it yet. It's isovolumetric, but they're getting ready to eject it by starting to contract. And so you can see this. This is called the ventricular systole phase, or isovolumetric contraction phase. So the ventricles are getting ready to contract. The AV valves are closed, and we're now pushing the SL valves open. And this corresponds to part of that QRS phase. So that QRS complex that we have here, and the ventricles are depolarizing at this point. So remember, QRS, ventricular depolarization, it's part of the ventricular systole. In the first part where we're just starting to contract, we haven't ejected the blood yet, but we're starting to contract it. So let's go on to the third phase. So we are now ready to talk about the mechanical physiology of the cardiac cycle. So cardiac cycle, we're going to go from heartbeat to heartbeat. So one cardiac cycle is one round of diastole, so the relaxation of the chamber when it's filling with blood, and one round of systole where it's contracting and trying to eject blood. So one diastole, one systole equals one cardiac cycle. Now, recall that atria contracting and ventricles contracting happen at slightly different times from each other, and that's due to the AV node delay. So recall that the action potential goes from the SA node to the AV node, where it slows down because some of those fibers don't conduct electricity well. But that's a good thing because we don't want our atria and our ventricles contracting at the same time as each other. We want the atria first and then the ventricles. So let's break this cardiac cycle down into four main phases. And we're going to try to figure out what's going on in the heart mechanically during each of these phases. And I think a good way to study this is to really just close your eyes and imagine the blood flowing through the heart, which you've already studied. And from there, try to imagine what's happening to the pressures inside each chamber. And from there, we can kind of go back and figure out what's going on in these phases. So let's first talk about the first phase, which is ventricular filling phase. And really, it's just what it sounds like. The ventricles are filling. And what are they filling with? Well, blood, of course, right? So blood, as you know, is draining from the atria into the ventricles through those AV valves, or, on the left side called the mitral valve and on the right side called the tricuspid valve. So blood is draining from the atria into the ventricles, and a reason why it does that is because of differences in pressure between the pressure in the atria and the pressure in the ventricles. In other words, we have a pressure gradient going on. So you've already learned about gradients. We've been talking about them forever. There can be concentration gradients, electrochemical gradients, all sorts of gradients. But when you're talking about what's leading to the different phases mechanically of the heart, we're talking about pressure gradients, where the pressure on one side is different than the other side, or in this case, in one chamber is different from the next chamber. So as the blood is draining from the atria into the ventricles, we're going to start to see a change in pressure, and we're going to notice that the pressures are different between the atria and the ventricles. So during the ventricular filling phase, when these ventricles are filling with blood from the atria, the pressure in the atria is going to be greater than the pressure in the ventricles because there's not that much blood in the ventricles right there, right? So it's kind of relaxed. There's no pressure on the walls of that ventricle, whereas the atria, which are filled with blood, that blood is putting pressure on the walls of the atria as well as pressure on those AV valves. That blood wants to go from where it's greater concentrated in the atria to where it's lesser, or from where there's greater pressure to where there's less pressure. So at this point, during the ventricular filling phase, the pressure in the ventricles is less than the pressure in the atria. It's also less than the pressure in the great vessels. So in the case of the left ventricle, the pressure is less than it is in the aorta. And in the case of the right ventricle, the pressure is less than it is in the pulmonary trunk. So during this phase, these AV valves are open, right? The pressure from the atria, from that blood, is putting pressure on those AV valves, opening them, further allowing that blood to drain into the ventricles. So while the AV valves are open, at this stage, during the ventricular filling phase, the semilunar valves, so the aortic semilunar valve and the pulmonary semilunar valve, they at this point are closed. And it's because the pressure in the ventricles is less than the pressure in those great vessels, the aorta and the pulmonary trunk. Now, just a side note, don't forget that about 80% of the blood going from the atria to the ventricles is happening passively. It's just going on through those where the valves are open. But another 20% is actually going to be ejected into the ventricles through atrial contraction. But most of it's just kind of passively filling, starting to fill up those ventricles. And that brings us to the second phase, the isovolumetric contraction phase. So the second phase, isovolumetric contraction. Iso means same, volumetric, volume, right? So the volume of blood in the ventricles is not going to change during the second phase of the cardiac cycle. However, the pressure is going to change. So now that we've gotten all that blood from the atria into the ventricles, they're filled up. That pressure has increased, right? It's increased a lot in those ventricles. And as that pressure from the blood is increased, it's putting pressure on the walls of the ventricles and putting pressure on those AV valves. And that's going to close those AV valves, preventing backflow or regurgitation of the blood back into the atria. So during the isovolumetric contraction phase, the AV valves are closed because the blood in the ventricles closes them. But because the pressure in the ventricles is still less at this point than it is in the aorta and pulmonary trunks, the semilunar valves are also still going to be closed. But at this point, because that pressure is building up, it's kind of like a volcano, right? That's getting the lava built up. It wants to go somewhere. It can't let that pressure stay where it is. It wants to go down its pressure gradient to where it's less pressure. And so this is going to trigger systole in those ventricles. Those ventricles are going to start to contract. They haven't ejected blood yet, but the muscle is going to contract. And even though the volume is still the same, it's not changed, but the muscles are going to contract. So let's look a little bit at this chart right here and kind of summarize what we've just been saying with the ventricular filling phase and the second phase, the isovolumetric contraction phase. So what's even cooler here is we can start taking these events, these mechanical physiology events of the cardiac cycle, and correlating them to the electrical events that are going on that are mapped on an EKG. And this is important to do because we're going to start building a graph over the next few slides, a very large graph where we're putting a lot of information on one graph. So stay tuned for that. So let's start off just looking here. The atrial systole begins. Atrial contraction forces blood into the ventricles. So this is what we were talking about regarding the ventricular filling phase, right? So the atria are contracting, so they're in systole, and these AV valves are open and the blood's starting to fill into the ventricle. Well, recall that on the EKG, the first wave is the P wave, and that correlates to atrial depolarization. So we're getting that electric current going through the atria, and we're getting the essentially dumping of the blood from the atria into the ventricles. So all that's going on during this ventricular filling phase, and it's correlating to the P wave on the EKG. Going on to that second isovolumetric contraction phase, you could consider this to be early systole in the ventricles. And just recall, it's also where the atria are repolarizing, but that's masked on the EKG. So during this early or first phase of ventricular systole, remember that the pressure is increasing in there because the the blood is filled up and it puts pressure on those AV valves and closes them, but the pressure is still less than it is in the great vessels, and so those SL valves remain closed. And so on the EKG, this correlates to that QRS complex, right? That's where the ventricles are depolarizing. But this is only the first part. We're only starting to contract those ventricles, but we have not yet ejected the blood. We're going to talk about that on the next slide. So let's go on to the third phase and the fourth phase, and then we're going to put it all together. So the third phase is called ventricular ejection phase. So you know that in the second phase, we were in early systole of the ventricles. The ventricles were starting to contract, but they hadn't yet actually ejected the blood out. So it's during the third phase, the ventricular ejection phase, that we're actually going to eject that blood out of the ventricles into the great vessels. Again, if you're talking about the left ventricle, it's going to go into the aorta. If you're talking about the right ventricle, it's going to go into the pulmonary trunk. So third phase, ventricular ejection phase, blood is ejected from the ventricles into the great vessels. And just like with the other two phases, this is going to be dictated by what's going on with the pressure gradients. So we just came out of the phase where both valves were closed. The pressure in the ventricles had put pressure on those AV valves and closed them, yet the pressure in the ventricles was still below that in the great vessels, and so the semilunar valves were closed as well. So now we need to open those semilunar valves so that we can eject that blood out of the ventricles and into the great vessels. And so in this third phase, the ventricular ejection phase, we finally have it so that the pressure in the ventricles is greater not only than the pressure of the atria, but also greater than the pressure inside the great vessels. So in this, what's written here, we're referring to the left side of the heart, but the same thing's happening on the right side. So when the pressure in the left ventricle is greater than the pressure of the aorta, it's going to put that pressure against the aortic semilunar valve. When the pressure in the right ventricle is greater than the pressure inside the pulmonary trunk, it's going to put pressure on that pulmonary semilunar valve. And in both cases, that greater pressure in the ventricles is now going to force those semilunar valves open on both sides, because essentially that blood is not only putting pressure on the walls of the ventricles, but it's now putting pressure on the walls of the vessels and on those semilunar valves, pushing them open. And so eventually, this is like the end of the contraction phase, the systole phase of the ventricles, when that blood is just like erupting like a volcano from the ventricles, pushed into those great vessels through now what are the open semilunar valves. Now, depending on the strength of the contraction, there's always going to be a little bit of blood left over in the ventricles. We are going to call this the ESV, or the end systolic volume. And on average, it tends to be about 50 milliliters of blood that's left in the left ventricle. And you are going to see usually a difference a little bit on the two sides. The left ventricle is going to be under greater pressure than the right ventricle. And of course, the muscle in the left side is greater than it is on the right side. So let's correlate this to the electrical activity in the heart during this third phase. So we've already been through the first two phases and correlated that with the P wave and the QRS complex on the EKG. Well, now we're in this second part of systole of the ventricles, the second phase of it. So semilunar valves have opened and that blood is ejected into the aorta and the pulmonary trunk. This is going to correlate with that T wave. So remember that the T wave itself is ventricular repolarization. So basically what's happening after that forceful contraction. So after that, at the end of ventricular systole, the second phase of it will then be entering the repolarization phase of the ventricles. Okay, so now we're ready to talk about the fourth and final phase of the cardiac cycle. And this is isovolumetric relaxation phase. So it's essentially the opposite as the second phase we talked about, the isovolumetric contraction phase. So just as the name implies, During this fourth phase, the ventricles are going to be relaxing. They're going to be going into diastole. And that's because they have just finished ejecting their blood. And now that pressure is released from the ventricles. We're now putting it into the great vessels. And so these ventricles are relaxing. The volume doesn't change. We're in isovolumetric phase. But we're going to start seeing a change in the pressures again. And so in this case, because we've gotten rid of all that blood that was in there, that pressure has decreased. And at this point, that pressure is less than it is in the aorta and the pulmonary trunk. And so that blood is now on its way through those vessels. However, as the pressure builds up in those vessels, that blood is going to want to sort of fall down, go backwards, and that's going to put pressure back on those semilunar valves and close them. So during this fourth phase, we're going to get a closing of the semilunar valves. Meanwhile, the AV valves are still closed because we haven't started the cycle over yet again. So pressure of the ventricles is still greater than it is in the atria during the fourth phase, but less than it is in the great vessels. And that blood backflow from the vessels is just going to put pressure on the SL valves and close them. So let's take a final look here. You can see the same thing happening in both of these pictures. So you can choose whichever picture you like. But let's talk about this third and fourth phase. So again, third phase here, the ventricular ejection phase, we're essentially between the S wave and about halfway through the T wave. So during that time, that's when the blood is being ejected. It's the second half of ventricular systole, and the blood's being ejected into the great vessels because the valves are now open. And in the fourth phase, we're coming down the mountain on the T wave because now we are in repolarization of the ventricles. They're relaxing, and all those valves are closed. So that is the cardiac cycle, 4 phases. So I hope you can study these charts and sort of think about what's happening both mechanically and electrically as measured on an EKG so that we can put both of these together very soon. So now we're at the part that you've all been waiting for, putting all that information you've gathered on a single graph called a Wigger's diagram. So we're going to take all the information we've gathered about the electrical activity of the heart, combine it with the information about the mechanical activity of the heart, and put it on a single graph called a Wigger's diagram. Now, here's a Wigger's diagram. And if you look at it initially, your brain probably goes into shock. You're like, what is that? And how am I supposed to make any sense of it? But it's actually a very clever diagram because you're going to be able to gather a lot of information in one picture. So what we're going to try to do over the next couple slides is break this down, go slowly, bit by bit, until it all makes sense, and then you can stand back and look at the big picture. So let's start breaking down what the Wigger's diagram actually shows us. So essentially what you're looking at when you're looking at this Wigger's diagram is the activity of the heart for one heartbeat. And a heartbeat lasts less than a second, about 0.8 seconds. And so during that time, we know that we have the cardiac cycle that we just went over, and that's considered mechanical physiology. And so on this diagram, we're going to be able to gather information about the volume going on in the atria and the ventricles, as well as the pressure going on in the atria and the ventricles. And we've already described these things just in our previous discussion about the cardiac cycle. Also shown on this graph, we're going to have an EKG, and it's lined up with the mechanical events of the heart. So we kind of already did this when we were talking about those 4 phases of the cardiac cycle, relating those phases to the electrical activity that's going on in an ECG. We're going to be able to see those 4 phases that we just talked about, and we're going to be able to correlate all of that with the heart sounds that we talked about, S1 and S2, lub, dub. So when you put all this together, it's really interesting to kind of see how the electrical activity, the mechanical activity, and the sounds of the heart all fit together. So related to these phases of the heart, you're going to be able to really see where the heart is in systole, especially the ventricles, versus where it's in diastole. So all of this information is available here. So you can see your phonocardiogram where you have your heart sounds, the electrocardiogram with the waves that we've already talked about, the volume in the ventricle, the pressure in the ventricle, and the pressure in the atrium, and the pressure in the aorta. And again, the phases of the heart correlated to all this. So all this information we are going to be talking about in our next slide where we break down the Wiggers diagram. Here we go. Let's start breaking down the Wiggers diagram and figuring out what's going on at each component. So this picture right here is an attempt at trying to simplify that larger Wiggers diagram that you just saw on the previous slide. So let's take a look at this starting with the diastole side, because remember that the first phase of the cardiac cycle was the ventricular filling phase where the ventricles are filling with blood. So let's start off, let's just start off down here at the bottom of the diastole part during the ventricular filling phase. So over here we have volume of blood that's left in that chamber, and over here the pressure that's inside that chamber, and up here we're going to look at how it correlates with the electrical activity on the ECG. So let's start right here. We're in the relaxation phase of the ventricles, and the ventricles have just emptied by ejecting the blood into the great vessels, aorta or pulmonary trunk, depending which side you're talking about. So we start with our end systolic volume, right? The amount of blood that was left in the ventricle after it ejected the blood. So remember that on average is about 50 milliliters. So there we are in terms of the volume at this stage on the Wiggers diagram. Well, now that it's in diastole, those atria are going to start draining the blood into the ventricles. So in other words, the volume is going to start increasing as it fills with blood. And we see that on the chart here. So it's going to start increasing all the way until we get to the end of ventricular diastole, and now it's filled up and ready to start contracting. So that's where that part of the graph comes in. Once it contracts, we then are in ventricular systole. And remember that that's going to start off with the isovolumetric contraction, which is phase 2 of the cardiac cycle, where the volume does not change. So at that point, that graph is going to be flat. And then during the second half of systole, where we're getting that ventricular ejection, we're ejecting the blood into the great vessels, it's essentially, going to very quickly lose the volume of blood from the ventricle and put it into the vessels. And so we're getting a rapid decline in volume back down to our end systolic volume, right? So that's what's going on there. And then during the isovolumetric relaxation phase, you don't get a change in that volume because the volume stays the same. And so you get a flat line there. So both isovolumetric phases, contraction and relaxation, the volume doesn't change. And so the graph looks flat. So that's for volume. Now let's take a closer look at what's happening with the pressure. So starting back with ventricular diastole. During the ventricular filling phase, remember that the pressure in the ventricle is very low because there's no blood in there. The blood's all in the atrium. And so you're going to see that in green here is the left ventricular pressure, and in purple is the left atrial pressure. So initially during that filling phase, because the blood hasn't finished filling into the ventricles, the pressure in the ventricles is lower than the pressure in the atria. And that's what causes the blood to put the pressure on the AV valves, such as the mitral valve, and open it on up. So at that point where they intersect, that's when the mitral valves are going to open, and that carries over. By the time we get to ventricular systole, of course, we had reversed the situation, and now the pressure in the ventricles is going to be much higher than it is in the atria, right? So now the ventricles are filled with blood and they want to eject that blood. And so the maximum pressure in the ventricles is going to be right in the middle of that ejection phase when that blood is being ejected. Once it's ejected, the pressure starts decreasing and eventually comes all the way back down until it's below that of the atria. So that's where that big hump comes in right there. Now, you can also correlate this to what's happening in terms of pressure inside the aorta. And so remember that during diastole, the pressure is much greater in the aorta than it is in either the atria or the ventricles, but certainly much greater than it is in the ventricles. But during the contraction phase, during systole, we see that that pressure has skyrocketed in the ventricles because they filled with blood. And in fact, for a short period of time, that pressure is going to be above what it is in the aorta. And that's going to allow the blood to be ejected. And as we said before, during this isovolumetric relaxation phase, that blood in the aorta and of course in the pulmonary trunk as well, the pressure's built up so high that it's now going to fall back and close those semilunar valves right there. So that's kind of how you read this chart in terms of pressure and volume. And now, of course, you can correlate this to the EKG. So just we've kind of already been through this, but just as a review, starting with ventricular filling phase, we're going to see that you're having no humps or waves on that EKG during the initial part of the filling phase of the ventricles, because you're just getting depolarization of the SA node, and then here's your P wave where you're getting depolarization of the atria, and finally by the end of diastole of the ventricles, they're now entering systole, and that's where you're getting that QRS complex here before they enter repolarization, and that's where you get that T wave right there. Okay, so that's a little bit of a breakdown. Let's go back to the original true Wiggers graph and see if we can make sense of it. All right, you guys ready? Let's do it. Let's take everything we've learned about the cardiac cycle and what we've been talking about the Wiggers diagram. Let's go back to our original Wiggers diagram, put it all together, and it should make sense to you. And if you can figure out the Wiggers diagram based on everything we talk about, you can learn anything in anatomy and physiology. So let's get started. We're going to break it down again, starting with the first phase of the cardiac cycle, which was the ventricular filling phase. So we know that during the ventricular filling phase, we are in diastole of the ventricles. So let's break that down again. So if we are in atrial systole, we know that we are in ventricular diastole. And so let's go ahead and go to the end of this where we're going to see a filling of the ventricles. Okay, are you guys ready? Are you ready? You ready to put all this knowledge back on the original Wiggers diagram? I think you are, and we're going to break it down some more. And remember, if you can learn everything about a Wiggers diagram, you can learn anything in anatomy and physiology. So it looks more complicated than it really is. If you understand how blood flows through the heart and what the anatomy of the heart is, you can understand a Wiggers diagram. So let's go ahead and start again with the first phase of the cardiac cycle, which was the ventricular filling cycle, right? When we're putting blood from the atrium into the ventricles. So that is ventricular diastole. And so we see this down here, right? Our ventricular diastole. So let's see what's going to happen here. So remember, during ventricular diastole, the ventricles are relaxed and the blood is flowing in from the atria through the AV valves. The AV valves are open, therefore allowing 80% of that blood to flow passively into the ventricles. And it's not till the end when the atria contract and force that remaining 20% out forcefully. So during diastole of the ventricles, we're talking about the ventricles here, we are going to have, right during that ventricular filling phase, a rapid increase in the volume of blood in the ventricles because they're filling, right? So we're going to go from what we started with right after they contracted and ejected the blood into the vessels during the previous cycle. We're going to go from that end systolic volume of -50, rapidly increasing it on up somewhere around maybe 120 or so. And so that's our rapid inflow. And so the graph is going to increase rapidly right there. This is our ventricular volume with this red line. It's going to continue going up until it reaches its maximum right at atrial systole, right? So right when the atria are going to actually eject the remaining amount of blood into the ventricles. And so coming down to the EKG here, we can see that while that volume is increasing rapidly in the ventricles, we are in the depolarization of the SA node here, that flat line before the P wave on the EKG. Remember, during the P wave, that's when we get depolarization of the atria. And so we're right here regarding how much filling is going on in the ventricles. And then they will continue filling to their maximum until basically the atria have to squirt out the remainder, that 20%. And that's right at the end before we get to the QRS complex. So at that point, we are at our maximum volume of blood in the ventricles, the maximum pressure, and they're putting pressure on those AV valves. And so those things are going to close. And so basically we are going to close those AV valves right here, where we are at our maximum ventricular volume. And now we enter ventricular systole, where we're going to get the beginning of the contractions. And that is, of course, that QRS complex. So let's expand out a bit and know that if this is where we are closing our AV valves, because it's the inflection point where we're going to get the ventricular pressure increasing above the atrial pressure, this is also the closing of the valve correlates, of course, to S1 heart sound on the phonocardiogram. So that's the lub, right, where the valves are closing. So that's where that happens. And now that we've reached our maximum, we've closed those AV valves, we're now going to be in this isovolumetric contraction phase where the volume of the ventricle is not going to change, but the pressure is now going to skyrocket, right? Because now you're at the maximum, the AV valves are closed, and it just that blood wants to bust out of there. And so it's at its maximum pressure before it busts out. And so the pressure in the ventricles is going to rise above the pressure in the aorta. And that, of course, is going to cause the semilunar valves to eventually open. So, and so we're going to get the ejection of the blood out of the ventricles right here at the top of that curve right there, right? Where the pressure in the ventricles is greater than the pressure in the aorta. And of course, it's much greater than the pressure in the atria at this point, which are emptied from blood. And so when we're at our maximum pressure, we are ejecting the blood. And so the pressure is going to decrease as we eject that blood. And of course, we're ejecting the blood out of the ventricles. So it's going to very rapidly decrease in volume all the way back to the end systolic volume of negative 50 millivolts. And at that point, we are in our isometric volume relaxation phase. So the ventricles are relaxing and we're still left with that 50 milliliters of blood that we are just kind of left there after it's done its ejection. And so now that we have gotten rid of the load there, gotten rid of all that blood that was in the ventricles, except for the last 50 milliliters that remain, the pressure is now just dropped way down. It's like, we got rid of it. The pressure's gone. It's dropped below the aortic pressure. And of course, we're going to get the aortic valves closing right there because the backflow in the aorta and that pressure is going to just close that aortic valve. And so that gives us our dub sound, right? Our S2 sound on the phonocardiogram. And in terms of what's going on the EKG, well, we know that at this point, once we've ejected everything, we're basically at the T wave, right? So now we're entering ventricular repolarization. And so we're on that T wave and coming down out of that T wave. And by the end of that isovolumetric relaxation phase, we are gone and done with that T wave and ready to start the next cardiac cycle. And of course, the volume or the pressure in the ventricles has gone way down and is now below the pressure in the atria because the atria are back to filling with blood and the ventricles are empty of blood. They're just now being filled up again. So that was one cardiac cycle. Let's review by coming back around to the next cardiac cycle here and see if you can follow along. So again, we are starting with, let's go ahead and start here. So we just ended the ventricular volume here where it's starting to fill up because now the ventricle pressure is less than that of the atria. The atria are pouring the blood down into the ventricles, so the volume is increasing. So it continues to increase here. We got our P wave there where we're getting depolarization of the atria. That is going to continue, and we're going to get atrial contractions. And then finally, we reach kind of our peak volume of blood in the ventricles. And that starts ventricular systole, which is going to correlate to the QRS complex and to the closing of the AV valves, including the mitral valve and the tricuspid valve. And so when those valves close, we hear our first heart sound, S1, lub. So that's right at the beginning of ventricular systole. And we know that when we are filling up that ventricle, we are increasing the pressure of the blood on the walls of the ventricle and against those valves. So the valves have closed, but the SL valves still remain open until the pressure in the ventricles rises above the pressure in the aorta and the pulmonary trunk. And at that inflection point is where those semilunar valves open. And now the pressure is built up so much in the ventricles that we want to eject it into those great vessels because the pressure is now greater than it is in the vessels. And so now we're in that ventricular ejection phase where we're going to eject blood into the vessels. And where we are at our peak here, we can see that we are still having a greater pressure in the ventricles than in the aorta and pulmonary trunk. And so now we are going to go into the ventricular repolarization phase. But because we've ejected the blood, the volume of the blood in the ventricles has gone way down. It's now in the blood vessels. And we are now basically by the end of the ejection phase, we are coming through the T wave on the EKG. And now the pressure buildup in the aorta and the pulmonary valve is going to cause those semilunar valves to close right as the pressure in the ventricles is falling below that of the atria so that they can start filling, starting the whole phase again. And again, at that inflection point where the pressure in the ventricles becomes lower than that of the atria, you get your second heart sound, the dub. So anyway, study this graph, break it down, take a piece of paper and cover up parts of it and just try explaining what's happening at each line here. It's kind of a fun brain exercise, but also will really help you to think about the events of the heart and all the stuff we've been learning about heart physiology. How does it all fit together? So the last major topic we're going to talk about is cardiac output. So in other words, we've been talking about all this blood going through the heart, how the electricity is going through the heart. So how much blood is actually pumped through the heart and through the body? So that is called cardiac output. And we're going to also talk about what regulates that cardiac output. So amazingly, every single minute, your body is producing and circulating about 5 liters of blood every minute. So every minute, 5 liters of blood is going through your heart and going through your body. 5 liters per minute. That is amazing. You know, if you think how much a liter bottle is or a 2-liter soda bottle, you can figure more than twice that is going through your heart and your body every minute. So that's called your cardiac output, or CO. So the amount of blood pumped through both circuits, so that means the pulmonary circuit and the systemic circuits every minute, 5 liters. So to calculate cardiac output, we have to know 2 variables, the heart rate and what's called the stroke volume. So your heart rate, on average, a healthy adult person is going to be about 72 beats per minute. So your heart rate is just the number of beats per minute. If you want to kind of determine somebody's heart rate, it's very simple. You could find a pulse like in the carotid artery and then just simply count the number of pulses, the number of beats in 15 seconds, multiply that by 4, and you have the number of beats per minute, the heart rate. But stroke volume's a little more complicated than that. That's the amount of blood that's ejected by the ventricle per heartbeat. So in other words, per cardiac cycle, how much blood goes from the ventricle to the great vessels during that ventricular ejection phase that we've been talking about. And so we already said that after a ventricle has ejected the blood, there's still blood left in the ventricle. That's your end systolic volume. And recall that that was about 50 milliliters. Well, your end diastolic volume, so the amount of blood that's in the ventricle when the atrium stops putting blood in there and that those AV valves close, that's about 120 millivolts. So your stroke volume, the amount of blood that actually got ejected, would just be that end diastolic volume, the amount of blood in the ventricles, minus the end systolic volume, the amount of blood left in the ventricle after it's tried to eject everything it could. So in this case, it would be 120 millivolts minus 50 millivolts, the amount left in there. And that gives you a stroke volume, or SV, of about 70 milliliters. And this is called your resting stroke volume. So again, it's the total amount of blood, like the maximum blood that you end up with in the ventricles before ejection. And then you're going to subtract from that the amount of blood left in the ventricle after it ejects it into the vessels. So 120 minus 50 gives you a resting stroke volume of 70 milliliters. So now that we have our resting stroke volume and we have a heart rate, because you took it, by the pulse, it was somewhere around 72 probably, you can figure out your total cardiac output, because cardiac output is heart rate, boom, times stroke volume, boom. That gives you your cardiac output, the total amount of blood pumped through everywhere, right? So I've tried to take this formula and just put it in a nice big flashy box here for you so you can remember cardiac output is heart rate times stroke volume. And here's a little chart that'll help you to remember what each of these terms mean and how it's affected. So now that you know what stroke volume is, we can start talking about factors that affect that stroke volume. So again, stroke volume is just your end diastolic volume, EDV, the amount of blood that filled in the heart, minus the end systolic volume. In other words, the amount of blood that is left in the ventricle after it ejects the blood. So one of the things that's going to influence that stroke volume is how efficient it is at pumping the blood that was there out. In other words, like it's more efficient if more of the blood gets pumped out as opposed to left in the ventricles after it contracts. So this can be calculated by something called the ejection fraction, which is just the percent of blood out of the total blood that was in the ventricle that is ejected with each ventricular systole, with each ventricular contraction. So to calculate ejection fraction, all we do is take the stroke volume and divide it by the end diastolic volume. So in other words, we want to take the amount that was, left after, the amount that was actually pumped into the blood vessels. So remember, EDV minus ESV, and divide that by how much you started with. So that gives you your ejection fraction. And as you can see over here, that, stroke volume divided by end diastolic volume. So remember we said your resting stroke volume is somewhere on average of 70 milliliters, and that your end diastolic volume, so the amount of blood you started with in the ventricles, is about 120 milliliters. So 70 divided by 120 gives you 58%, right? And so 58%, so that means, somewhere between 50 and 65% of the blood that you started with was pushed out into the blood vessels. So this little chart here is going to tell you, kind of where these values fall in terms of the health of the heart. So if you have greater than 70% of that blood being ejected into the vessels and not left in the heart or in the ventricle, that is high functioning, normal, 55 to 70% of it. But like just going on down, if you have less than 40% of the blood that filled up in the ventricles getting pushed out into the blood vessels, that blood's going to have a hard time getting around, and that could be possible heart failure. So this is an important value to calculate for determining the health of the heart. So let's talk about some of these factors that affect stroke volume. So one of the things that can affect stroke volume is what we call preload. So preload is a measure of how much the cardiac cells of the ventricle stretch. The stretchier they are, the more the ventricle is stretched out, which means the more space there is for blood to fill in it. And so you get increased filling of blood as you get a stretching of the walls of the ventricle, because those correlate to a stretching of those contractile cells, specifically the sarcomeres of those contractile cells. So the more those stretch, the more they can recoil during contraction, and boom, you get a stronger contraction. So your end diastolic volume, in other words, the amount of blood that can be held by that ventricle, is going to increase the longer you stay in diastole. So the longer it stays relaxed before it contracts, because obviously more time means you can get more blood into there. And also, the more blood that was pumped into the systemic circuit through the aorta during the previous contraction means you're actually going to get greater preload the second cardiac cycle around, because once that blood has been pumped through the systemic circuit, that the then deoxygenated blood that returns to the heart is going to have a great influence on the preload, because ultimately it will influence the amount of blood that will go into the ventricles. So so the more blood that's pumped into the systemic circuit, because you'll end up having more blood into the right atrium, and that's going to lead to higher preload. So related to all this is what's called the Frank-Starling law, which is just saying the more you're stretching out those contractile cells, the greater the force of contraction will be as a result. So the more you stretch, the more they want to, boom, spring back into place and give you a stronger force of contraction. Okay, so we said there are 3 factors affecting stroke volume. So the first one we just talked about was preload. So preload is the volume of blood in the ventricles at the end of diastole. So in other words, you know, how much blood you can fill in there. So what you got to work with, right? The second thing is contractility. So this is the ability of the heart to actually pump. What's going to be the strength of that contraction? In other words, it's the ability of that heart to generate tension so that we can force that blood out. And so this is going to be related to the end systolic volume, because this is, of course, you know, the more you pump out, the lower that end systolic volume will be. So the higher the contractility, the higher the stroke volume is going to be, and the lower the end systolic volume is going to be. Or a way to look at that is the less you have less blood you have left in the ventricle after you've tried to eject it all, that means that you're going to have a higher stroke volume. That means more blood was pumped out, which means you have higher contractility because you're good at pumping stuff out. So, you know, you can look at this cartoon and say, okay, here's preload. So that was the volume of blood in the ventricles at the end of diastole. Contractility is how good it is at pumping it out. And now we have a third factor that affects stroke volume, and this is the afterload. And so that's the force that's needed to then eject the blood from the ventricles. So contractility dealt with kind of the tension that's there that, you know, affects the ability of the ventricles to pump the blood out. But this is, afterload is the actual force that's needed to eject that blood. And so this goes back to those pressure gradients that we've been talking about. So afterload is essentially the pressure that you need in the ventricles to be able to overcome the pressure in the arteries within the systemic circuit of the body. So how much pressure is the whole system under that the pressure in the ventricles needs to exceed in order to pump that blood through the body. And so that's called the afterload. So another way of looking at that is the pressure that's needed in the ventricles to overcome the pressure in the great vessels in order to open those SL valves so the blood can go in. So as you increase the afterload, in other words, as you increase the force that's needed for the ventricles to overcome those SL valves and open them up, that also correlates to a lower stroke volume and a higher end systolic volume. Because remember that the more blood that's left in the ventricles, that means that you didn't have good stroke volume, right? You weren't very good at pushing most of that blood out. That's why a lot was left in the ventricles. And that's correlated with the fact that it was not able to overcome the force needed to have the pressure in the ventricles exceed that in the great vessels and open those semilunar valves. So in other words, it had high afterload. So just to recap here, afterload is the resistance that the left ventricle has to overcome to circulate the blood, whereas preload was the volume of blood that was in the ventricles at the end of the relaxation phase. So to summarize it again, your stroke volume is essentially a combination of three main factors. The preload, which is the volume of blood filling the heart. As it increases, you increase the stroke volume. Contractility, which is the ability of the heart to contract. So how strong are those contractions? And as contractility increases, so does stroke volume. And finally, afterload is the resistance to the pumping of the blood. And so obviously, as you increase your afterload, you decrease the stroke volume. So all those feed into that calculation of stroke volume. And as we said, cardiac output is your stroke volume times your heart rate. So we've been talking about factors that affect stroke volume: preload, contractility, and afterload. But we also know that heart rate is directly associated with cardiac output. And so let's talk a little bit about the factors that can affect heart rate. So again, cardiac output is stroke volume times heart rate. So either one of those getting manipulated. If you have factors affecting stroke volume, it'll affect cardiac output. And if you have anything that affects heart rate, it's going to affect cardiac output. So overall, heart rate is affected by chronotropic agents. In other words, things that either speed up the heart rate or slow it down. We can contrast that with something called inotropic agents. So inotropic agents are things that affect the strength of contraction of the heart, but chronotropic agents are things that affect the heart rate. And this chart right here gives you a comparison of those two concepts, dealing more with synthetic drugs that serve as chronotropic or inotropic agents. But for the next couple minutes, let's talk about things naturally in the body that serve as chronotropic agents. So you can speed your heart rate up through what are called positive chronotropic agents. These have to do with things released by the SNS, the sympathetic nervous system, which we'll talk about in a little bit, hormones, and increased body temperature. So for example, if you're running a fever, then you probably have felt that your heart rate increases. And then the opposite of that would be negative chronotropic agents, which are the parasympathetic nervous system, rest and digest, and low body temperature. So if you're very cold, let's say you were out in the snow, your heart rate actually could decrease. So remember, sympathetic nervous system, fight or flight, parasympathetic nervous system, rest and digest. So you now know that there are factors that affect stroke volume, preload, contractility, and afterload, and there are things that can affect heart rate, both the nervous system through the sympathetic and parasympathetic branches, as well as the endocrine system. So let's go ahead and put these concepts into seeing how overall we affect cardiac output, the amount of blood that pumps through the body. So let's first talk about how the nervous system affects cardiac output. So just like with heart rate, we're going to be talking about the fight or flight, sympathetic nervous system, or rest and digest, parasympathetic nervous system. So as mentioned before, epinephrine or adrenaline increases heart rate and increases stroke volume. So it is released by the sympathetic nervous system And when that, and it's going to be released, by the way, through vesicles, because at that point it's acting as a neurotransmitter, just like some of the things we had talked about before when we were talking about the nervous system. So epinephrine, not only is it going to affect heart rate and the stroke volume by increasing them, but one of the ways it does that is by increasing the rate of firings, action potentials, generated by the sinoatrial node. So the more firings you have, the more those action potentials propagate through the heart, reach those contractile cells, and cause the contraction of the ventricles and eventually of all the chambers. And so, so the more firings you have, the more stuff happens, more contractions and relaxations, and therefore more blood that gets pumped out. So you increase your cardiac output. And along the way, recall that as you're propagating the action potential, you're also dealing with calcium. And calcium, as we said, with cardiac cells, is found more in the extracellular fluid than it is inside the sarcoplasmic reticulum. And so as you are increasing the amount of epinephrine to the heart, that causes an increase in the calcium ions moving through those calcium channels we talked about before. That ultimately causes contractions of the sarcomeres inside those contractile cells to happen more frequently. And therefore, that increases the contractility of the heart and the overall stroke volume, thereby affecting and increasing the overall cardiac output. The reverse of that is we are making use of the parasympathetic nervous system to slow down the heart rate and decrease the stroke volume. Again, decreasing the amount of blood that is ejected out of the ventricles. And this is going to be thanks to cranial nerve 10 of the parasympathetic nervous system, also called the vagus nerve. And if you were there when we talked about vagus nerve before, everything happens in vagus, right? It can do all sorts of things, including slowing down the heart rate, decreasing stroke volume, and thereby decreasing cardiac output. How does it do this? Well, it releases a neurotransmitter that acts as the opposite of epinephrine. It releases acetylcholine, and acetylcholine decreases the rate of action potential firing from the SA and AV nodes. So that's how the nervous system affects cardiac output. But as we said, it's also affected directly by the endocrine system. So let's break that into hormones of the endocrine system that can increase cardiac output and those that can decrease the cardiac output. So we've already said epinephrine is something that increases cardiac output. So prior, we were talking about how it is released by the sympathetic nervous system, but as we know, it is a hormone of the endocrine system, and epinephrine and its related partner norepinephrine are released by the adrenal medulla of the endocrine system. And so when that's released, it has the same effects as it does when it's released by the sympathetic nervous system. It will increase cardiac output. Thyroid hormone produced by the thyroid gland. Remember, thyroid gland is involved in metabolism, including increasing the cardiac output from the heart, which increases metabolism. Glucagon from the pancreas. Remember, glucagon is responsible for increasing the amount of sugar available in the blood. So the more glucose available in the blood, the more you can do cellular respiration and generate ATP. And so the more glucagon that's there, the more energy there is for pumping blood through the heart, and so the cardiac output increases. And finally, we have aldosterone and antidiuretic hormone, ADH. If you recall, these both are responsible for making less pee by the kidneys, right? So they tell the kidneys to increase the blood volume in the body and by decreasing the amount of urination occurring. And so the more blood you have in the body, the more preload you're going to have into the ventricles. And so in other words, you have more blood to work with to start with, and that's going to increase your cardiac output. And finally, how can we decrease the cardiac output using the endocrine system? Well, you might recall this funny sounding hormone here, atrial natriuretic peptide, or ANP. So ANP is a hormone that will do the opposite of aldosterone and ADH. It will decrease the blood volume, thereby decreasing the preload. So you have less blood to work with to pump out, and so your overall cardiac output is decreased. So these charts over here give you a nice little summary of everything we've been talking about. So in terms of cardiac output, affected by heart rate and stroke volume, right? Cardiac output is heart rate times stroke volume. Heart rate can be affected by nerves and by hormones. Stroke volume by resistance, vascular resistance, and blood volume. But related to that, nerves and hormones. And this is kind of a grand summary chart for cardiac output. You know, it's a measure of heart rate times stroke volume. And these are all the things that we just talked about that affect each of those variables. So stroke volume is affected by preload, contractility, and afterload. Heart rate is affected by hormones and the sympathetic and parasympathetic nervous systems. And so this will kind of just break that down, just basically summarizing everything we just talked about cardiac output. That does it for our discussion of cardiac physiology. Thank you so much for sticking with us. I hope you learned a lot, and I will see you in our next A&P lecture.